This lecture will include a discussion of the various roles and functions of the physical therapist and the physical therapist assistant, as well as examine the boundaries between the PTA and the PT in regard to education and clinical practice. So let's first look at the definitions of the PT and the PTA. This will frame the discussion for the roles and responsibilities of each. The physical therapist is the professional who works to evaluate, treat, and/or prevent physical disability, movement dysfunction, and pain resulting from injury, disability, disease, or other health-related condition. The PTA is a healthcare provider who assists the physical therapist in the provision of physical therapy and has graduated from an accredited PTA associate degree program. The key points are that the PTA functions with the PT in compliance with federal and state regulations, so there's a partnership with the PT. And the legally defined degree of supervision and autonomy varies state by state. The primary role of both the PT and the PTA is, of course, patient care. You will hear the terms primary, secondary, and tertiary care. Primary care refers to the entry point in the healthcare system for an episode of care. Secondary care refers to care based on referral, and tertiary care refers to care from a specialist. So, for example, a person with back pain may go to their family physician, which is primary care. The physician then may refer the patient to PT, which in this case would be secondary care. Again, direct access is available in all states, so the person with back pain could go directly to the PT, in which case the PT would be practicing primary care. Anyway, the PT functions in patient care by examination and evaluation and application of direct interventions. In addition, the PT can delegate direct interventions to PTAs or other personnel as specified by state law. The PTA functions in patient care by conducting tests and measures as delegated by the supervising physical therapist and applying direct interventions as delegated by the supervising physical therapist. The duties of the PT and PTA are described in state law and APTA policy. As for APTA policy, the core document that describes practice is the Standards of Practice for Physical Therapy. This policy includes all aspects of the profession and includes sections on ethical and legal considerations, administration of the physical therapy service, patient-client management, education, research, and community responsibility. This document is available in your text and on the Bibliography tab on eCollege for this course. In addition, the Policy on Direction and Supervision of the Physical Therapist Assistant, also available in your text and on the Bibliography, describes supervisory relationships between the PT and PTA. You should review this policy in great detail. It describes the duties and responsibilities of the PTA and the portions of practice that are exclusively the domain of the PT that cannot be performed by the PTA. Duties are also based on state law. These laws supersede APTA policy. In other words, if a state law conflicts with APTA policy, the law is to be followed. Anyway, all 50 states have a law referred to as the Practice Act that describes the duties and responsibilities of the PT and PTA. You should become very familiar with the law of the state in which you practice. In order to obtain a license to practice, you have to graduate from a CAPD accredited school, which makes you eligible to sit for the licensing exam. You must pass a test that includes practice questions and jurisprudence questions. The jurisprudence questions relate to the state law for that particular state. For example, In Minnesota, it is legal for a chiropractor to refer patients to physical therapy. In Michigan, it is not. Once the test is passed, you are licensed to practice. And again, the State's Practice Act will describe your duties and responsibilities as a practitioner of that state. For example, some states have limits on the number of PTAs that can be supervised by a PT. Others do not have specific language to this issue. The key points: the PTA graduate must understand the principles of authority and responsibility based on state law and APTA policy and practice in an ethical, legal, safe, caring, and effective manner under these policies and laws. Now let's look at PT and PTA education. If I were to ask you what are the similarities and differences in PT and PTA education, what would you say? Well, the similarities are that both types of education programs have a didactic and a clinical component. Didactic meaning classroom study and clinical meaning on-the-job training. So for example, you will have coursework, and this will be followed by field experience in which you go to a healthcare facility and learn how to care for patients under the supervision of a clinical instructor. This is where you will practice the tests and measures and intervention competencies that you have learned in the classroom and lab setting. Both PT and PTA programs have these components. The differences between PT and PTA programs come in the depth of knowledge, autonomy of practice, and evaluation skills. Recall that a PTA program is at the associate degree level, while the PT program is at the doctorate level. To be eligible for admittance to a PT program, one must have a bachelor's degree with an established record of success in biological sciences, physics, chemistry, mathematics, and psychology coursework. Therefore, the depth of knowledge for course content in a PT program is far deeper than that in a PTA program. For example, PT students learn the science behind many of the techniques you will learn. Another difference is the acquisition of evaluative skills. Physical therapist students learn diagnosis and differential diagnosis. Recall that diagnosis is not a duty performed by a PTA. PTs, on the other hand, have the duty to examine patients, diagnose the problem, and develop a treatment plan for a patient. All these duties are beyond the scope of PTA practice. These duties are what give the PT autonomy of practice. Now let's look at the patient-client management model. The patient-client management model describes the process of clinical practice and the duties for the PT and PTA. As you review this slide, you see the components of this model: evaluation, examination, diagnosis, prognosis, and intervention, and who is responsible for each component. Study this model well as it frames the clinical process. Now let's look at each component in detail. Now let's look at the examination process, which is the sole domain of the physical therapist. The first component is patient history. This consists of questioning the patient or family member about the patient's condition. For example, can you tell me where it hurts? Have you had this problem before? Have you been treated for this problem before? Have you had a diagnostic test? A seasoned PT can learn much about the patient's problem from these questions and will often have a good idea what the problem is at this point. The patient history is followed by the relevant systems review. So the systems include the cardiopulmonary, neuromuscular, musculoskeletal, and integumentary systems. So what do we mean by a relevant systems review? Well, for example, if a PT is treating a patient for a total hip replacement, but that patient also has a cardiac condition such as congestive heart failure, the PT should do a review of the cardiopulmonary system to determine the patient's capacity to withstand exercise and to monitor the patient's reaction to exercise. After the relevant systems review, the PT will conduct tests and measures for the main issue for which the treatment is sought. This can include observation, manual techniques such as range of motion, manual muscle testing, examination of joint play and soft tissue mobility, and it also can include environmental examination. So, for example, in the case of the patient with a total hip replacement, the PT will observe their ability to move in bed, ambulate, and balance. They would also take range of motion measurements of the affected joint and strength tests of the lower extremity, upper extremity, and trunk muscles to determine at what level of intensity rehabilitation will commence. Once the examination process is complete, the PT performs an evaluation. This is the process by which the PT makes a clinical judgment based on the examination, based on the tests and measures. This judgment is documented in the medical record and is the sole domain of the physical therapist. Based on this evaluation, the PT makes a PT diagnosis, not to be confused with a medical diagnosis. A PT diagnosis is a categorization of findings. Examples of PT diagnoses include impaired posture, impaired muscle performance, impaired joint mobility, motor function, muscle performance, and range of motion associated with capsular restriction, ligament or other connective tissue disorders, localized inflammation, fracture, joint arthroplasty, or bony or soft tissue surgical procedures. Another PT diagnosis is impaired joint mobility, motor function, muscle performance, range of motion, or reflex integrity secondary to spinal disorders. And finally, impaired gait, locomotion, and balance, and impaired motor function secondary to lower extremity amputation. These are all examples of PT diagnoses. There are several more. Also, if the PT feels the patient's condition is beyond the scope of PT practice, a referral to another appropriate provider occurs. Examples could be referring for counseling or referring back to the physician. After evaluation, the PT makes a prognosis, which is a prediction of the level of improvement and time necessary to reach that level. An example of a PT prognosis could be something like, the prognosis for this patient is excellent. The patient will return to pre-injury level of function within 4 weeks. This is an example of a prognosis for a patient with the ability to recover fully from their injury. Another example could be something like, the prognosis of this patient is poor. The patient will be able to ambulate with an assistive device with a minimal assist within 4 weeks. This is an example of a person who may never return to their previous level of function. An example would be a patient that has suffered a stroke. After establishment of a diagnosis and prognosis, the physical therapist will develop the plan of care. This includes goal setting, which should be measurable and include family and patient input. For example, a goal could be, the patient will ambulate independently within 4 weeks. These goals are the expected outcomes for the patient. After developing goals, the PT will describe the interventions that will be used, including the type, duration, and frequency. So, for example, the plan of care could state therapeutic exercise will be used for lower extremity strengthening, twice a week for 3 weeks. This gives the activity and the duration and frequency of the activity. In addition, the PT may state the discharge criteria, which is what level of function does the person need to obtain to be discontinued from treatment. An example of this would be in an acute care hospital, for example. The patient will be discharged once they're able to ambulate with a walker, a minimum of 20 feet with a minimum assist within 1 to 2 weeks. Now let's review the intervention component of the patient-client management model. Interventions are the domain of the PT and PTA. PT and PTAs conduct procedures with the patient to reach the desired outcomes. Interventions include coordination, communication, documentation, patient-client related instruction, and direct interventions. As for coordination, communication, and documentation, this is essential for positive outcomes. Communication between the PT and PTA is critical in optimizing progression of a patient. Also, communication between the various providers in the care team is essential for those patients being seen by more than one provider at a time. An example of this would be a person who has suffered a stroke, who is in a rehab hospital and receiving occupational therapy, physical therapy, speech therapy, and physician services at the same time. In this case, communication minimizes duplication of services and all can be working on collective goals. Another vitally important intervention is patient-client related instruction. As a PTA, you will be on the front lines educating patients and their caregivers regarding their conditions and programs. For example, a patient suffering from back pain will need instruction on the anatomy of the spine so they can understand their pathology. They will need instruction on proper body mechanics to minimize stresses to the back, and they will need instruction on how to perform exercises that will improve their function. You will use instruction, demonstrations, audio-visual aids, and pamphlets to educate your patients. Patient education is vital. It allows the patient to assume responsibility for their rehabilitation and encourages active participation. It is essential for the desired long-term effects. Clinical time is usually not enough. Education should be used with all patients as possible. Sometimes it is very difficult, as in the case of a patient with Alzheimer's disease. And finally, we have the direct interventions. These include therapeutic exercise, functional training, the use of modalities, and the use of assistive devices. We will cover these in detail in a different lecture. Examples in your slide include functional training, which we see here, person being trained to ambulate on the steps. Here we have some exercises for the back to strengthen the back and learn how to coordinate muscle contraction. And here we have a hamstring stretch. These are examples of direct interventions. So we have covered all the components of the patient-client management model, but let's revisit examination, or in this case, re-examination. During the course of rehabilitation, it is the PT's responsibility to periodically re-examine the patient. This is identical to the examination process previously discussed. The re-examination allows the PT to determine if the course of rehabilitation is on track or needs revision. Examples of outcomes based on a re-examination include: number 1, revising the treatment plan. So the physical therapist could choose to add new interventions, for example. Another example of an outcome of a re-examination may be revision of goals or adding of new goals. For example, if the original goals are not being met, the time frame may need to be changed. The PT may also decide to revise the delegated duties, so they may increase or decrease the delegation of interventions to the PTA and others. An example of this would be in the case of sciatica, where a patient is not improving. In this case, the PT may want to perform all the interventions for the patient to monitor the symptoms more closely. Another outcome of a re-examination could be referral to another provider. For example, the patient isn't improving and the PT suspects a pathology that is outside of the scope of practice. And finally, goal achievement and discharge. If the patient is ahead of schedule, early discharge may be warranted.